Today's topic is cannabis and dementia, and it's one that often challenges our assumptions about where cannabinoid therapy actually fits into care. Because when most people think about dementia, cannabis is not typically part of that conversation. And yet, what we're beginning to learn through emerging research and clinical experience and patient and caregiver reports might surprise you. From managing agitation to supporting sleep, overall quality of life, there's a growing interest in how cannabinoid therapy might play a role, not just for those living with dementia, but for families and caregivers who are supporting them. We're incredibly fortunate to be joined again by Dr. Bonnie Goldstein, who will be taking the reins in just a moment. She'll walk us through what we know, what we don't know yet, how to thoughtfully and safely approach cannabis and dementia care. We're also joined by Catherine Golden, who's Executive Director and founder of Leaf 411, which is a national nonprofit cannabis nurse hotline, who will help ground us in the practical patient facing side of this work. If you connect with her, you'll learn more. And for those who I haven't met, my name is Sasha Kalchif-Korn. I serve as Executive Director for Realm of Caring, and nonprofit dedicated to advancing cannabis research, education, and access. So, through the organizations represented here today, you'll have access to trusted education, support, and vetted resources to help guide you, like what you can find at goldsteinwellness.com. So, whether you're exploring cannabinoid therapy for yourself, a loved one, or the patients you serve. So as we go, just a quick reminder to use the Q&A box for any questions that come up. I think we'll have some time at the end today to go through as many as possible. And we'll also be sharing helpful resources in the chat along the way and in the follow-up email along with the recording. So to kick us off, Catherine, if you'll share a little bit more about Leaf 411, and then we'll hand it over to Bonnie.
Sure. Thank you so much. So today's presentation is I'm proudly supporting Leaf 411, a national nonprofit helpline and guidance call center delivering evidence-based cannabis education through nurse-led support. Our nurses bridge the gap by speaking both languages, traditional healthcare and expert cannabis, so you can have real informed conversations about what's right for you. And we're just proud to support Bonnie and Realm of Caring, and this topic is really dear to our hearts. So we're excited to hear. Thank you.
Thank you. All right, Bonnie, we'll pass it off to you.
All right. Can you see my screen?
Looks
Yes?
great.
Okay, great. So welcome, everyone. Thank you so much for taking time out of your busy day to join us. My name's Bonnie Goldstein. I've been a physician for 35 years in California, initially in pediatric emergency medicine, and then in 2008, I made the transition to medical cannabis after witnessing the benefits in a friend fighting cancer. And I'm so glad I did because what I do is so very rewarding. I have many adult patients that I've taken care of over the years, and then I started treating children with epilepsy and autism and other serious conditions. And so my practice just the last few years has focused on pediatrics. However, I still have many adult patients in my practice who I've been following for many years, some of them for like 15 years. It's been really just wonderful to have relationships with these folks. Anyway, so today we're going to talk about cannabis and dementia, specifically, as Sasha mentioned, how it can help with some of the most challenging symptoms. And my goal today is to walk you through what we know, what we don't know, and just how to think about cannabis for dementia in a practical, balanced, helpful way, taking away some of the noise that sometimes accompanies the idea of using cannabis as medicine. And of course, I want to take a moment to thank our sponsors, Realm of Caring and Leaf 411. Both have been leading the way, helping people understand and use medical cannabis treatment effectively and safely. Please, it is absolutely worth a phone call to either organizations or both to just understand maybe your situation, your loved one's situation, anything that can give you clarity in this kind of, sometime this world where we see controversial articles being published, and then we have doctors like myself who are saying, oh no, it's absolutely indicated. It can be confusing. So please feel free to reach out. And then just a little thing for me that I want to share with everybody. April 7th was Charlotte Figge Day in Colorado. I celebrate it here in California. I just want to take a moment to acknowledge Charlotte Figge, as you know, who was a little girl with Dravet syndrome who was treated with cannabis after being sent home with a very poor prognosis. Her mother, Paige, has been leading the way and has both she and Charlotte have shined a light basically on the life-changing potential of cannabinoids, and they've had a lasting impact on patients and families all around the world. So I just wanted to say thank you to them, and hopefully as we move forward with the government hopefully changing from Schedule 1 to Schedule 3, and maybe the FDA defining hemp and helping us make it such that access is better and we don't have different patchwork, it would just be nice to honor these families who have led the way by making access better for people all across the world, actually. All right, so we're going to get started. So let's get started with definitions. These are important so that we're all kind of talking about the same thing. We're all on the same page. So dementia is not a single disease. It is a clinical syndrome. It is a group of symptoms. Many people just think about memory when they hear dementia, but it's really more than that. It affects your judgment, your language, your behavior. And when do we actually call it dementia? And we call it dementia when it starts interfering with day-to-day life, with activities of daily living, knowing to put your pants on, knowing what day it is and that you have a doctor's appointment that day. For many people living with dementia, this is when we start to see the loss of those daily functions, okay? Now, you also may hear the term neurocognitive disorder. And so that just simply refers to conditions that affect the brain's ability to think. It may affect memory, it can affect reasoning, being able to make decisions, but understand that neurocognitive disorders are kind of on a spectrum. They range from mild, you can have something called mild cognitive impairment where you're still functioning during the day. You might be forgetful, you may have difficult sorting out some more advanced like executive function tasks, but at the same time, you are still able to be independent and you're still able to take care of yourself. But remember that mild cognitive impairment is, again, on that spectrum and may slowly over time, especially if there's an underlying process going on, may lead to dementia or, the mild, moderate, or severe dementia definition. But remember, when it interferes with daily life, we are calling it dementia. Now, neurodegenerative and neurocognitive, what's the difference? Neurodegenerative actually refers to progressive brain cell damage. And the examples are here: Alzheimer's, Lewy body disease, Parkinson's, dementia. Not all Parkinson's patients have dementia. Parkinson's disease, you can still be independent, you can still function, and you may not have dementia. You may not get dementia, but certainly there's a process there where the brain cell damage is happening and may lead to dementia. Frontotemporal dementia is also as part of this, and that's a very difficult one because it's behavior heavy. There's disinhibition associated with FTD that can be very challenging to treat. So remember, neurocognitive disorders that are not neurodegenerative include stroke, TBI, so traumatic brain injury. Also be aware that a neurocognitive disorder can be induced by medication. Somebody can take medication and they completely become somewhat demented, right? And also there's metabolic issues. So things like thyroid disease, that is reversible. If you can identify it, it can affect judgment, memory, and so on. But if you can identify it and reverse it, remember, it's not neurodegenerative. Vitamin deficiencies like B12, there's also infections. So many older adults will get urinary tract infections and act as if they have dementia. When the infection is treated properly, their brain issues clear up. Also, issues like blood sugar imbalance. So blood sugar can also cause issues. So just be aware that there are some neurocognitive disorders that can be reversed. This is why diagnosis is so important and why somebody who has the beginnings even of this should be checked for their medication list, should be looked at, their blood work should be looked at, and potentially they should be evaluated for stroke or a potential my dad started to have neurocognitive functions. This is a long time ago. He had slipped and fallen And he kept saying, no big deal, I didn't hit my head. And it turns out that he had a subdural hematoma that was responsible. And once they drained the blood, he turned around and was back to his normal self. So it's very important that you get the proper diagnosis. Another thing I wanted to address before we get into the meat of the research is the medication burden in older adults. So we know that there are many medications that we commonly use to manage symptoms in older adults, some with mild cognitive impairment, some with full-blown dementia, treating things like agitation, anxiety, sleep, and pain. And I'm sorry, I'm just going to say this. As a medical, in the medical world, the pharmaceuticals, sorry, they get like a D- grade. They're just not great, especially in older adults where they can actually make things worse. There is a set of guidelines called the Beers criteria, BEERS, as you can see there from the title. It is a list of medications that may be inappropriate for older adults because of the side effects. And remember, too, at the same time, and that you can look up and take a look at the medications, but they include things like the antipsychotics, sleep meds, anxiety meds, nausea meds, muscle relaxants, pain medications, some antidepressants, and so on. And we know that those are being prescribed quite a bit because we know that for older adults, there is a problem of polypharmacy where they're taking multiple medications that can all, let's say, be sedating, or they can cause confusion. 35 to 45% of older adults are thought to have polypharmacy, and it's even higher, approaching 50% in frail individuals and nursing homes. And I saw even one number like 70% in nursing homes or assisted living facilities. So here in the United States, it's like 4 in 10 older adults are on medications that may, and I'm calling it soft here, may not be beneficial, might actually be causing problems. So again, that's very important to look at. And the reason that there is growing interest in cannabis is because it can be, and I will use a term that one of my younger patients used, a 27-year-old who was on 7 different medications when she came to see me, and she was able to eliminate all of them. She came in and she said, here's my bag of medicines. When I use cannabis, and she was using, of course, illegally. This was way back when, before it was legal here in California to obtain it over the age of 21. She said, I have gotten some, and it handles everything that these medicines are supposed to handle. And she said, I call it my one-stop shop. And, she's not wrong. And why is that? It's because we know these cannabinoids hit multiple targets in the brain and body and can take care of symptoms, many different symptoms in different mechanisms, but again, all with the plant medicine. So what's happening in the aging brain, either with or without dementia? Okay, so we know that the process of dementia, but also just aging brain, there's inflammation, there's something called oxidative stress, which I'll talk about in a second, and also loss of how cells communicate with each other. So for lack of a better term, we are basically a big skin bag of cells. I know that sounds weird, but that's what we are. We are a whole bunch of cells, and our cells are smart. They can talk to each other, sending chemical messages. And that is what we start to lose as we age. Oxidative stress, a helpful way to think about oxidative stress is just to think about a piece of metal that you leave outside. When it's exposed to oxygen and air, it starts to rust and it starts to break down. It's like wear and tear, but slow over time. That's what's happening in your brain cells, is slowly they're building up. I call it rust, but they're building up these like free radicals, and they're building up inflammation. And very importantly, something that we must understand is that all of these processes are regulated, at least in part, by our endocannabinoid system. And remember, the endocannabinoid system is really the basis of understanding why cannabis can act as medicine. If it's used as medicine, it is medicine. And so remember that what we see in the endocannabinoid system, and this has been sorted out in aging animal brains, what we've seen is the parts of the endocannabinoid system start to age, and we see changes in, let's say, how many receptors are present. Is the endocannabinoid system functioning well by sending its signals properly. And that does start to age, just like the rest of us, right? And so can we use this endocannabinoid system as a target using medicine or cannabinoids from the plant to target that system? So I'm just going to show you again, and I used this slide in last month's, but I changed the photo out. I found something a little bit more appropriate for this talk. The endocannabinoid system regulates just everything that keeps you in balance: immune function, your inflammation, your pain signaling, appetite, mood, sleep, but very importantly, cell survival and cell death. So we talked about this in our last webinar about cell survival and cell death as it relates to cancer and how the endocannabinoid system is involved in cancer care. Well, it's interesting in dementia, what's happening is the cells are not mutated cells that are taking over. They are cells that are sending imbalanced messages. And by addressing the endocannabinoid system, augmenting it, enhancing it, we now have a target to help put all of these various survival type functions. I mean, you want to get sleep, you want to have a good appetite, you want to be able to understand when your body's in pain, you want to control your inflammation, all of that again related to a functioning, healthy endocannabinoid system. And so at its core, the endocannabinoid system is the signaling system. And I went through this in the last talk, but I'll go through it briefly here. We have cannabinoid receptors. You can see here, it's like a lock on your cell. And then we have these endocannabinoids that your body makes in response to an imbalanced message. Your body says, "Ooh, there's an imbalanced message. Let's try to get it balanced." Kicks out endocannabinoids made from healthy fat. This cell is talking to this cell by sending these neurotransmitters. You can see here it's labeled, sending across that message. This cell is getting a wrong message, imbalanced. It kicks out these endocannabinoids that travel backwards to the sending cell, like a key in a lock. And when the key goes in the lock, it sends the message to this cell, for the most part, dial back on the messaging. Usually it's a overstimulatory message. And we know that phytocannabinoids from the plant can substitute for the endocannabinoids, and specifically one endocannabinoid called anandamide, THC, mimics it very closely. And again, there's also enzymes that we talk about as part of the components. These enzymes help you make your endocannabinoid, help you break it down. But the whole idea here is homeostasis, right? And as the brain ages, and especially in neurodegenerative diseases, the balance is disrupted and you get more inflammation. Like the normal aging brain, it's accelerated. So you get more inflammation, you get excessive signaling, and you get greater vulnerability of these neuronal cells, these brain cells, to the damage. So again, the idea behind the plant is to help restore that balance. Let's move into the preclinical research. So this is test tubes and animal models. And believe it or not, there's too much for me to even go over here, like to include. I can't go through every study because there's so many of them. And that's very reassuring that at least we're starting to get those preclinical studies going so that we have understanding and data that we can then take to the human population. So when you look at the models studied, almost all of them have been studied: Alzheimer's, just general aging, neurodegeneration, and neurotoxicity models, where they sometimes give some type of brain cell induced progression of neurodegeneration. They kind of create toxicity in the brain and then try to rescue it with the cannabinoids. The frontotemporal dementia, Parkinson's, is actually one of the ones where it has the most research, believe it or not. And then Huntington's disease, which is a more rare but genetic neurodegenerative disorder. The cannabinoid study, well, look at the list. These are many that are already available on the market that you can purchase. And the question becomes is, which one of these might be most beneficial? Which one of these might fix, my relative or my loved one or help them with their symptoms? And remember that most of the studies have been done on THC and CBD, but there is emerging work on these other cannabinoids listed. And it seems just as a general statement that I can make is that when you combine the cannabinoids, you may get a better effect than a single compound alone. And that supports the idea of synergy, or these what we call entourage effect, where the compounds together can enhance the benefits, and again, often at lower doses, and also minimize side effects. What were the key findings? So if you look at all of these studies, I try to kind of put them all together. What do most of these studies show? So in these preclinical animal models, across the board, the cannabinoids appear to reduce inflammation. So we've talked about this in other webinars, and this is a big one. These cannabinoids are anti-inflammatory. And if you were to line them up in terms of which one is the most and which one is the least, it just depends on what you're looking at, what cell lines, what animal model, what human condition you're looking at. So, but all of them are pretty good anti-inflammatories. They all also help with that rust problem that I mentioned, oxidative stress. They help to provide protection against oxidative stress, and also also lead to neuroprotection. So remember, these are the key drivers of neurodegenerative disorders: inflammation and oxidative stress. So that neuroprotection is very, very important. And I want to share with you also, so we have these proteins that they have found with Alzheimer's, amyloid plaques and tau tangles. Kind of easy to remember, T and T go together, tau tangles. So amyloid are these plaques, that protein deposits that build up in the brain. They're outside the neurons, but they interfere with neuron function. And the tau tangles occur inside the cell. I don't know if you could kind of see in this picture here, these plaques on the outside, this is the neuron, and the tau tangles are inside. But in these preclinical models, numerous preclinical models show this. This isn't just a one-off, that cannabinoids specifically reduce the buildup of plaques and tangles. They reduce the damage from the plaques and tangles, and they support cell survival. This is very important. Again, mostly THC and CBD. Now, what about cognition in these animal models? So we've seen variable effects on cognition. So, for instance, in an animal model of Alzheimer's, the mice might not be able to go through a maze and find the treat at the end of the maze. But in some mazes, or in some studies, when they're given cannabinoids, that particular ability comes back. It's very interesting, right? And so some of these studies do show a pro-cognitive or improved cognition in some of their models. And of course, the results depend on the model, the dose, and the cannabinoid studied. When this is posted, we'll have a list of all the articles that I use to look at. And so you'll be able to see which studies are kind of support these findings. And in general, though, overall, what I can say is that most of these studies show very similar results, in that cannabinoids are helpful for these particular mechanisms of action. Now we're going to move on to human studies. So let's take a look at what we've seen so far. So a lot of the clinical research we have comes from Parkinson's disease, which, remember, isn't always dementia, right? Not everyone with Parkinson's gets dementia, but it is a neurodegenerative condition, meaning that there is progressive cell damage, and there are overlapping symptoms, things like changes in thinking, mood issues, sleep disruption, some behavior issues. There have been, between 2001 and 2014, there were 6 small human clinical trials, and you add them together, it's only 57 patients. But I think it's meaningful to look at what was found. The treatments included synthetic THC. So there are a handful of synthetically, which means laboratory-made THC. You can get prescribed, like let's say for cancer, you can get prescribed a drug called Marinol, which is a synthetic THC, which is supposed to help with nausea, vomiting, appetite. I've had some patients get it in states where THC is not readily available, and they're able to use. We get the psychiatrist on board or a developmental pediatrician, and they'll recommend and they'll be able to prescribe a THC to a family who's really in crisis mode. But when you compare synthetic THC, and I talked about this again last time when we had the webinar for cancer, synthetic THC compared to natural, most people prefer natural if they've been given an option. But also these treatments included THC extracts, so there was natural THC, and also some studies included CBD, but it was purified, or what we call pure, like 98%, 99% CBD, which means it's not full spectrum. It doesn't have all of the compounds that occur naturally in the plant. Interestingly, 5 out of 6 of the studies found statistically significant clinical benefits. That's what the SS is, statistically significant, which means not by chance. And so what they found was that the patients who had Parkinson's had reduced drug-induced dyskinesia. Dyskinesia is involuntary movements from the drug. And oftentimes, if you're on a drug, the Parkinson's drugs long enough, you will develop this. And patients found that it helped with these involuntary movements. Patients reported improvement in thinking, anxiety, and also some psychosis symptoms. Also improved sleep, pain, tremor, rigidity, and bradykinesia, which is one of the symptoms of Parkinson's where it's just difficult to get started moving. And also, there was one study that reported some improvement in REM sleep disorders in patients with Parkinson's. And they were 75% had significant improvement in that sleep disorder. And I don't care what anybody says, you're not sleeping, no matter what condition you have, even if you don't have anything else, you're pretty miserable. And one thing that cannabis does for, I would say in my practice, at least 90% of the patients who come to me with sleep issues report benefits with sleep. So we do know that cannabinoids can really help with that. So here we have very interesting results from early studies. This is like, almost, what is that? Over 10 years ago. So, and longer. So we do have data showing in humans that cannabinoids can help with significant symptoms from Parkinson's. Here's another report. So this came from, I'm sorry, I don't remember, but this is a self-reported effects of real-world cannabis use in Parkinson's. It was a survey, and this was published in 2022. 1,881 Parkinson's patients, 73% reported medical cannabis use. And I think that speaks highly of how these patients, feel better on cannabis. That's 3/4 of these patients were using cannabis, and maybe many of them may not have even had any medical guidance or discussion. Most took 1 dose per day. The majority, I think it was 55%, were on CBD dominant, and then the next group were THC dominant, and then about 15% of patients were using a 1-to-1 balanced CBD THC. And greater than 50% reported improvements in pain, anxiety, agitation, and sleep. Interestingly, higher doses of THC had more frequent improvements in depression, anxiety, and tremor. And remember, why would THC do that? So one thing that's very important to understand is THC mimics anandamide. We learned this from our very esteemed researcher, leader, professor, Dr. Raphael Mechoulam, who studied cannabis for over 50 years in Israel. He was the one who isolated THC and named it THC. And so he has really led the way with research, and he has said all along, anandamide can be replaced with THC. We do not have, like when somebody has diabetes, we can give them insulin, right? We can replace what they're deficient in, what their body is missing. That's type 1 diabetes. If you are missing anandamide, we do not have anandamide to give you, that inner cannabis compound that we all make in our brain and bodies. But we do have THC that can substitute for it. And again, medical use of THC is using the minimum effective dose to give the benefits, kind of trying to mimic or tickle the receptor with THC. That's kind of a way to think about it. And that's why it makes sense. Remember, your anandamide is actually helping to manage your emotional well-being. And it's also involved in movement disorders and so on. So if your endocannabinoid system, the cells that normally would be responding with an endocannabinoid system response, those cells are inflamed, they're not functioning well. You can kind of tickle those receptors with THC. So just be aware of that. And that is why sometimes in these studies, we do see that often if there is a difference or different products like this, CBD dominant, THC dominant, or balanced, sometimes you will see one working better than another. In one of the studies from Dr. Gruber in Massachusetts, she was looking at neurocognitive function in people who were tested at baseline and then started cannabis treatment, and they were looking at neurocognitive function. But also assessing all symptoms. One of the things they found was CBD seemed to work better in their group for mood, some mood, but also THC patients reported better results in pain. Also, some better with sleep. So, depending on the study and depending on the population, we may see different responses to these different compounds. They work differently. They work for most people, when you combine them, they work very well. This is why THC is so important. CBD does not replace anandamide. What about side effects? Well, so all side effects that are well known, dry mouth, dizziness, feeling high, can be mitigated by changing dosing, changing product, changing timing. This is where, clinical advice can sometimes be very helpful to try to mitigate. And what I would say too is for those people who are super sensitive to THC, CBG appears to have some overlap with THC. I discovered this in my research with autism, and other groups have reported similar findings. So CBG may be a better fit for somebody, but also CBN, which is THC's kind of weaker cousin. So we have a lot of options. Again, I'm showing you the research, but in the real world practice, there are other options that one can try if they have side effects that they don't like. This is a report by a colleague, Dr. Meckler. He runs one of the largest neurology practices in the United States. He collected data, and this is in New York. He collected data on patients with Parkinson's, and most of the patients there were using a CBD THC ratio of 1:1. And this data comes from people who were in the medical cannabis program in New York. And when New York's program rolled out, initially the clinicians had to be specific about what they were recommending to their patients. And so based on some of the previous studies, Dr. Meckler realized, we need to include some CBD in here. And so, I'm sorry, THC. So he was mostly recommending CBD THC. And very great results. 87% reported improvement in cramping, dystonia, pain, spasticity, lack of appetite, dyskinesias, and tremor. 56% of opioid users were able to decrease or discontinue opioids. And very importantly, very well tolerated with no severe adverse effects. They had a very low rate of discontinuation from side effects. And in those patients who discontinued, this ratio may have been just a little too much THC for the amount of CBD. And again, in the real world, if somebody had issues with this ratio, you would switch it up, maybe go to a higher ratio, or try a different cannabinoid. So again, but very nice results. I mean, 87%. We don't see that very often with the pharmaceuticals that are being used for patients with these conditions. Now, what about safety? So there's not a lot in terms of human safety for dementia, but of course, clinically, we know it's very safe, especially when you have some medical guidance. Now, this study, though, was a safety study, and it compared 76 people using cannabis for Parkinson's, and they were matched by like age and level, of symptoms to people who were not using cannabis. And they were followed over anywhere from 1 to 3 years. And basically, they didn't find any worsening of thinking, mood, or any psychotic symptoms. And there was no evidence that cannabis made the symptoms worse over time. So this study suggests that long-term cannabis does not appear to negatively impact. I will share with you that in my practice, my patients who have dementia, their loved ones are over the moon with the results. They think they're great because they're struggling, as you well know, and then things get a little bit easier. And I just haven't had anybody tell me that their loved one is worse once we dial in. Now, remember, there are studies that show that most side effects of cannabis medicine starts or occurs in the first few months. Well, that makes perfect sense because that is when you're figuring out how does this particular person respond to cannabis medicine, especially if they haven't had it before. And so remember, you always start low, go slow, and sometimes you have to pivot if there are side effects. It's very hard to predict somebody's response to cannabis. I've been doing this a long time, and I don't care who you are, what symptoms you have, I still can't predict how you're going to respond. It is always in the beginning, and I always educate my patients and I make sure they understand in the beginning we want benefits, but we're also still just trying to figure out, is this appropriate for you? And if so, which product, which dose, which cannabinoid? And it's an exploration over time. It's really no different than when you think about pharmaceuticals. I have patients that have been on 7 different antidepressants looking for benefits. How that's any different from us sorting out which cannabinoid and which dose. Side effects are easier, and I don't have to necessarily wean people off off to make a switch. So I actually find cannabis medicine to be a little bit easier. One thing to point out, this was not a randomized trial, but I do think that it gives some reassurance, especially along with clinical experience, that long-term safety is really not a big issue. Okay, overall, what do the studies show in terms of other, not Parkinson's, but what about everything else? So human trials, the cannabinoids studied mostly are THC and mostly synthetic dronabinol or nabilone, and then THC CBD combinations have been looked at and definitely associated with findings of improved symptoms. So less agitation, behaviors, and improved sleep, appetite, even weight gain. In general, for safety, in human studies, again, of dementia, so Alzheimer's, FTD, and so on, well tolerated. And the most common side effect is sedation. Usually sedation is either too much THC, too much cannabis in general, or cannabinoids combined with other heavily sedating medications or polypharmacy. It's important to keep in mind, of course, that these studies were small. They did not have a huge number of patients. I'm going to share just a couple with you, but at the same time, I think clinically, and we've been talking about this, using cannabinoids for dementia for many years, many patients we know are doing quite well. Just this is one of those very real examples of where the research has not caught up with the clinical and what we're doing out in practice. All right, let's see. Next. Okay, so this is a randomized placebo-controlled trial, which, again, unusual to find with cannabis, but they are out there and they do exist. So this one had 60 patients with dementia. The average age was around 79, 60% were female. They used a 30-to-1 CBD to THC oil, and they also crossed over with placebo. And just they treated for 16 weeks, so 4 months. And that's important because you want to make sure if you're putting somebody on any medicine, of course, that the effects are sustained, beneficial effects are sustained over time. And, just as an aside, I meet so many people who have been on medicines for so many years, they say, I don't even know what it's doing anymore. And many of you may have experienced that with yourself or your loved one. But I do think it's important with cannabis. You cannot just say, oh, it doesn't work after 2 weeks. That is not the best way to trial cannabis. Obviously, if there's negative side effects, you want to change things around to mitigate those. But at the same time, we want to give cannabis a chance to work. So there were statistically significant improvements on the agitation scale at 16 weeks compared to placebo. Couple of things. The average dose in this study was high. It was for CBD. It was around 525 milligrams a day. Do you have to go that high? No. not always, especially if you're combining cannabinoids. They did find the treatment to be safe, no significant differences between drug and placebo. And let me just show you the graph. As you can see, the CMAI score, that's the Cohen-Mansfield Agitation scale. This is a scale where you kind of rate how agitated somebody is. And as you can see, patients, this is where they started. This is their baseline at time 0. And this is going over 16 weeks. And as you can see, the placebo group, they had some improvement. And, it might be that the family member or the patient themselves reported, I'm feeling a little bit better. But then it kind of levels out, and then it kind of even climbs a little bit at that later time period. But what you see with the medicine, and they just put the strain name here, it's from Israel, it's, I think, Avidical. You can see this improvement over 2 weeks, and then there's continued improvement over the 16-week period. So it is important to show on a couple of things here. One is it's a randomized trial. You see these 2 little stars up here. That means that this was statistically significant, the differences between the placebo and the intervention. So meaning that it wasn't due to chance. It's not like they picked people to get the drug who got better. Was not due to chance. This was actually due to the intervention. And also important that they also reported that the dose did not correlate with the age of the patient or the outcome. And that just, again, points out the idea here that it is not one size fits all. It is truly, even though here they did use one formulation, but they titrated dosing to the patient's needs and did pretty well overall, which is great. Let me just think if there's anything else. So I do think that this study does, kind of prove it provides some of the stronger evidence for us that cannabinoids can help with agitation. And this is the one that if you are dealing with a neurologist or a psychiatrist or somebody, or just even your primary care doctor who may be still a little bit on the fence, even though it's not a very big study, I think, just even showing somebody this graphic and saying, it's something that our family has decided to try, it supports you. And I think it's important to have that support. I'm going to share some, okay, I'm going to go a little bit faster here. We have a case report, 75-year-old man with Alzheimer's. This was published in the Journal of Medical Case Reports. He had progressive decline despite being treated with standard medication. He had Alzheimer's, and he was treated with a THC dominant extract, and you can see the ratio 8 times more THC than CBD in his particular product. But they microdosed him 0.3 to 1 milligram. And if you want to read the article, can just Google that title right there. But basically what they found, and you'll see in the paper that there's dosing that goes up and down, but he was basically followed for 22 months. And this is a guy that went from being unable, at the time that he started using cannabis, he was unable to take the bus by himself. He couldn't find the bus stop. He couldn't get on the right bus. He was having a lot of trouble. And they have him, a quote in the study after he was treated, he was able to get on the right bus and get to the doctor's appointment, to be able to share that he was able to do that with his clinician. So he had significant improved cognitive scores that looked at memory and thinking, and everything else was improved. His independence, his orientation to date, time, place, daily functioning, sleep, mood, and no significant side effects. So very interesting case report, and supports the idea of low dose treatment. And some people even might call this ultra low dose. There's a handful of literature on ultra low dosing, which may be very helpful for somebody. And again, this is why I tell people start at a pretty low dose so that you can see, because some people just don't need big doses at all. Now, this was a case, three case reports that reported on specifically frontotemporal dementia. And these patients, as you can see in this column here, key behavioral symptoms, significant disinhibition, compulsive behaviors, agitation, insomnia, anxiety. They don't really talk about the intervention other than they used a combination THC CBD. And across all 3 cases, there were improvements in behavior, social interactions, mood, better sleep was reported. And again, as with the previous case report, case reports are not exactly desired by the medical community. They want to see the randomized controlled trials. But here it just shows you three not very old patients with FTD have improved quality of life with improved symptoms with a combination of THC and CBD. Again, just adding to our understanding of how patients might benefit. And I just want to say too, I do not think as a clinician, again, this is my personal medical opinion, is that cannabis should be last resort. I recently spoke with a cousin of mine whose parent is having dementia, and they wanted to I forget the name of the drug, but it's one of these newer antipsychotics, and it says right there, big letters, may cause death in a patient with dementia. And I don't understand why somebody would recommend that for her parent who had dementia. So I do not think cannabis should be last resort. It is safe, especially with medical guidance. Now I'm just going to share my patient, and then we can stop and take questions. So this was an 84-year-old who came to me with Lewy body dementia for 4 years. He stopped talking. He wasn't smiling. He was aggressive towards the family and towards caregivers that were coming into the home. He was not sleeping. He had balance issues, poor appetite. He was on a bunch of medications that were worsening his symptoms, including an antipsychotic, an SSRI, a benzodiazepine. And they just saw him getting worse. And they were actually thinking about, we don't think we can keep him at home anymore. And it was a very close family. One of the daughters was an RN, and she kind of took the reins. And when I asked her, what are our goals of treatment? She said, we'd like to see him sleep through the night. We definitely want to calm the aggression. We'd like to keep him at home. So we need the behaviors to be not dangerous, and just overall improvement in quality of life. So the first thing we started was low dose THC at night, literally drops. And I got this email a few days after starting. He's sleeping through the night since we increased his THC to 2 drops at bedtime, 2 little drops. I think it was about 2.5 milligrams. And he started sleeping. And of course, the family's on board. They're like, let's go. So we started a CBD oil 25-to-1 ratio, and we titrated him up. I think he got up to 100 milligrams BID. I think that's what I've saved on my slides because I don't remember. But anyway, he continued the THC at night, and they were able to also, if during the day got a little ramped up, got a little excited with something, if he seemed like more behaviors were going to, and they knew at this point because they've been dealing with it for 4 years, they would just give him 1 or 2 drops and he would calm down. Sometimes he did not fall asleep. He would just hang out on the couch. He did not appear to be under the influence. He was just calm. And sometimes he would take a nap and he'd wake up in a great mood. Over time, and I took care of him for almost, I think, about 2 years, they reported resolution of the aggression. So they didn't see that anymore. He was sleeping great. He actually started having conversation. He started smiling and laughing. It wasn't always appropriate, but he was happier. His appetite got better. He had lucid moments. He started participating in activities, and he did pass away peacefully after being, in the next 2 years or so. And I just want to show you something. He loved to cook, and he had stopped cooking years earlier. Here he is helping the family cook. And here he is feeding the food that he helped make, which he couldn't do prior to cannabis. He was being hand fed by the family. So some things can come back, and that just, makes me very excited. So what does all of this mean? Well, so cannabis can help with all of these symptoms we talked about. It may replace other medications. I do highly recommend that somebody looks at medications who knows about cannabis to make sure that you're not taking something off that may have another reason. Sometimes drugs are repurposed, but also many patients are able to combo medications and have significant benefits, mitigate some of the side effects of some of the medications, because you can either lower the dose or just help with the patient feels better from the cannabis, which helps with the side effects. We see that sometimes like with ADHD and other conditions, epilepsy. And also CBD dominant products, very important, may improve mood, energy, provide neuroprotection, overall function, quality of life. The effects can be dose dependent. If you try a low dose, it didn't work, you should try a medium dose and a higher dose. Again, if you need help, reach out. We're all here to help you. But it's less likely to help with severe agitation on the own of these products. So I encourage people to remember that there is THC, there's THC's weaker cousin, CBN. There's also CBG, which has some crossover for pathways with THC. And then, of course, we have a slew of other cannabinoids that may help if somebody is only getting a partial or a poor response from CBD THC combo, or if it's contraindicated. There aren't very many medication contraindications, but if someone is on warfarin, or if they're on a drug called tacrolimus, or some other medications that where you're concerned, we do have these other cannabinoids, although we really don't have the research. All right, upcoming webinars, please join us. These are May 7th for Cannabis for Anxiety and June 4th for minor cannabinoids, where I'll be going through all of those cannabinoids I talked about today. And then, as we always say, you don't need to do this alone. Please reach out to all of us, to one of us. We're very, very happy to help you figure out how cannabis can help you or your loved one. I have lots of resources and partnering with these wonderful partners. And I just want to thank you for your attention.